All right. Hello, everyone. So for translations tonight, we're having the wonderful Dr. Brosious from UNLV, who specializes in gender-affirming surgery, speak tonight a little bit about himself and what he does, and show some pictures of his fabulous work, and just get to know him. And if you guys have any questions, we hope to bring him back within the next coming months. If you want to start off, Brosious, with who you are.
All right. So good evening, everybody. Some of you may have known me from either being patients of mine or when I was at the center. God, it was probably over a year ago now. But again, my name is John Brosious. I'm an assistant professor of plastic surgery at UNLV, and I'm the founder of the gender surgery program at UNLV. I've been in practice for 7 years. I've been doing gender surgery almost that entire time. I started in Pittsburgh, Pennsylvania. I was practicing there for 3 years and doing gender surgery in smaller doses because insurance was not covering it then. And then when I took a position here at UNLV several years ago, I started seeing more and more of the transgender patients coming to me for surgery when they heard that I was willing to do some of these operations. And now that insurance is paying for most of these surgeries, the floodgates kind of opened up, and my practice really transitioned from kind of a bread and butter reconstructive practice, as well as cosmetic practice, to about 2/3 of what I do now is gender surgery exclusively. So my background is in complex reconstruction, breast reconstruction, cancer reconstruction, a lot of trauma, burns, cosmetic surgery, head to toe. I also do, and gender surgery was a nice kind of segue into this for me because I'm used to working head to toe on every body part, being creative, being artistic with some of the procedures. And for me to do gender surgery was kind of a natural next step because I do a lot of chest reconstruction, cosmetic chest surgery for cancer, breast reductions. So it was very simple for me to start learning gender surgical techniques of the chest. And then I do a lot of pelvic reconstruction for anal cancers, rectal cancers, radiation damage to the pelvis, burns to the groin. So I've done reconstruction on the pelvis my whole career as well. So I felt like I was pretty well suited to learn the genital surgeries as well. So I ended up training in vaginoplasty, and I started performing those operations this past August, and we've been doing them since then at UMC Hospital. And I'm planning on performing phalloplasties. I was hoping to do them by now, but with COVID and everything, I have a group of urologists that need to train on their part, and so I do have some colleagues at other universities that are willing to let us go shadow them and bring those techniques to Las Vegas. So I'm still shooting for phalloplasty to be offered here in Las Vegas by summertime, maybe. It really depends on when COVID allows us to go train at these other institutions. So that's kind of where I am in a nutshell. I've also kind of spearheaded this coalition of medical providers. One thing that I realized very early when I got to town and wanted to do gender work is that I needed to find a whole group of other professionals to help me out. So I've recruited a whole group of psychiatric professionals. Some of them are psychiatrists, family therapists, other mental health professionals that can assist with not only the letters but also just the mental health perspective of the care. I had to find endocrinologists, pediatric endocrinologists, urologists, gynecologists, family doctors, ear, nose, and throat doctors. And so I basically rounded up everybody in town who's interested in gender care, both surgical and medical, to kind of create this coalition between UNLV doctors, local doctors, so that at least we have a network. So when patients come to me and need a letter, need hormones, need a hysterectomy, I know exactly who to send them to. They're going to be trans friendly. They're going to be vetted by myself and my team and by my patients. And so I'm very confident in sending referrals to all of these providers. So that took about 2 years to kind of build that. Gender surgery is really my passion. I didn't think that this was going to be my passion until I started working with the transgender community, and realized that I can really make a big difference as one individual for this marginalized community. As a matter of fact, people always ask me, how did I get into this? And my very first patient that I took care of was in Pittsburgh. It was a transgender woman, and she came in for breast surgery. And at the end of the consultation, she started crying. And I you what did I do to hurt you? And she said, no, you didn't hurt me. You're the only doctor in the entire city of Pittsburgh who took me seriously and treated me like a human being. And so her surgery went off without a hitch, and I had never had a happier patient, a more appreciative patient. And that's when I realized that, this is crazy that at this point, early maybe 2014, 2015, that patients have nowhere to go and they're still being treated like, second-rate citizens by physicians. And so that's when I kind of really got this passion for gender care. Again, insurance wasn't really paying for these procedures back then, so it was still few and far between. But when I came back here to Nevada, I realized that, with the insurance covering the top surgeries, the bottom surgeries, that I could really make a huge difference in this community. And like I said, I've never had a more grateful patient population. And so I felt like, this was my best way to help the most people, and to make a huge impact on people's lives. Not that, patients that have cancer, trauma, certainly I make big impacts on them. But for most of the gender surgeries, I mean, these patients have been waiting and thinking about these surgeries for so long that it's such an intimate procedure for them, that I really get to not only have, this physical connection with them through surgery, but an emotional and a mental one. So for me, I get such gratification from taking care of this patient population who, oftentimes has nowhere to go in the medical field. So that's kind of who I am in a nutshell, and what I do in Las Vegas here with UNLV. So what I thought I would do was, there's a list of kind of pre-planned questions that I'm going to go through, typical questions patients may have. So I'm going to go through these one by one, and then everybody wants to see before and after pictures. That's just like you don't get a tattoo without seeing your tattoo artist work. Like, you want to see what your plastic surgeon is going to do to you. So I've been putting together lectures for medical professionals. I give talks not only locally, but virtual talks around the country, actually, on gender surgery. So I pulled one of my lectures where I can kind of show you some before and after pics. And then I have some pictures of post-op vaginoplasty patients that I can share with you as well. And all of these are my patients. These are not like patients I found on the internet. These are all my patients, and they've all consented to have their likenesses shown for educational purposes like this. So, I think at one point I'd like to come back when we have in-person meetings at the center. I'd like to come back and I'll put together a nice lecture that's focused more on the patient perspective, not so much on the healthcare perspective, for the medical providers, that I can give to the audience there, and be there in person and interact with some of you guys as a true, lecture for you. So that'll be, hopefully in upcoming months as COVID slows down and things start to reopen. Hopefully I'll be able to provide that for you. But I'm hoping that, what I can show you guys today, tell you today, will at least answer most of your questions, get the ball rolling, until I can physically get there and in person. So without further ado, let's just go through these questions. Some of them I already kind of answered. So, the first question is, what made you want to specialize in gender affirming surgery? And I think, I've kind of already answered that. This is really, I became a doctor to help, to help people. And I'm not a religious person. I grew up Catholic, but not really religious anymore. But, I did maintain that one thing from my upbringing, is that, help the underserved, help the poor, help the marginalized. And as a plastic surgeon, I think this is the best way that I can actually kind of do that. So, without being religious, this is my way to kind of, I guess, follow the golden rule and that kind of a thing. So I feel like this is my kind of calling in plastic surgery. As far as procedures that I currently do, we've talked a little bit about this. So I do all the top surgeries at UNLV. So that's chest masculinization surgery, which includes the bilateral mastectomy with the nipple grafts, which is the most common operation I do in terms of chest masculinization. And I also do maybe 10% of the time in the select patients, I'll do the peri-areolar technique, where it's the minimally invasive. You make a little cut around the nipple and do the mastectomy that way. That's also known as the keyhole in some communities as well. And so I do that operation. I'll show you some pictures of that. It'll give you a better idea of that. As far as the bottom surgeries for the trans men, I will hopefully be offering phalloplasty by summertime. Like I said, that's COVID permitting. I was hoping to have done them already, but I still need to get my urologist trained up and ready to go for that. So still shooting for summertime. I have a list of patients who are, it's basically a callback list of patients who, once I am able to, get the ball rolling and start scheduling surgeries, we're going to call them back to the office. So if that's something that you're interested in, you can call and get put on the list. for phalloplasty. Metoidioplasty is something that that's more of a urologic procedure. And so I do have 3 urologists here in town who I finally pinned down, and all 3 of them said they'd be willing at some point to learn metoidioplasty. So again, that's going to be COVID depending when they're able to travel and learn that operation. But I do plan on, not myself personally offering that, but I do have somebody in my team offering that. Hopefully, I'd like to say by the end of this year, but again, it really all depends on kind of what's going on with COVID. As far as other procedures that are offered by me, I do head to toe cosmetic surgery. So, body contouring, that kind of a thing, fat grafting. I will do that from time to time. Unfortunately, insurance doesn't pay for that. So, that's kind of hit or miss. I have recruited other people at UNLV to perform different procedures. As far as facial feminization, one of my colleagues, Dr. Joshua Goldman, he trained in craniofacial surgery. He actually has been scheduling patients for facial feminization surgery. So we do offer that now here currently. I think he has his first one scheduled for next month already. Again, that's hit or miss whether that's covered by insurance. Usually it's not, although there are some really good insurance program plans. Like I know Amazon has good coverage, and there are some other places in the country like California, Colorado, where facial feminization is getting paid for. So it's only a matter of time until that will be paid for here by insurance in Nevada. But as of right now, it's mostly a cash pay thing. But I have Dr. Goldman who can offer that. And he's also in my same office with me. The ear, nose, and throat team from UNLV actually has been willing to see patients for not only tracheal shave, which is the Adam's apple surgery, but also voice modification. So one of my colleagues, Dr. Joe Bigas, I believe he's already seen a patient or two for consultations for surgeries that involve changing the pitch of the voice. Again, this is typically not covered by insurance at this time, but at least we have somebody in town who's skilled enough to offer these procedures. As far as other procedures, I do have a group, UNLV, of gynecologists that will do the hysterectomies. I have 2 good urologists who will be willing to do orchiectomies. If you don't want the vaginoplasty, you just want an orchiectomy, they can do that. And I do the vaginoplasties by myself. So if you just want orchiectomy, I'll have to guide you to my urologist, because I'm actually, I know it sounds silly, you can do a whole vaginoplasty and do an orchiectomy as part of the vaginoplasty, but I'm not basically, really, they don't want me doing simple orchiectomies because that kind of falls into urology. So again, it's just politics at the hospital. So if you simply want orchiectomy, we can guide you to the right urologist. If it's vaginoplasty, I'll be your guy for that. And I offer full depth vaginoplasty, which is what most patients want, and also 0 depth vaginoplasty for patients who aren't candidates for the full depth or who simply don't desire it. And then there's even a surgeon in town who's a colleague of mine who's an orthopedic surgeon who does limb lengthening and limb shortening, and he's seen several transgender patients to basically make them taller or shorter to be more congruent with your gender role. Also not paid for by insurance, and so that's a very pricey operation, as you can imagine, to make yourself taller or shorter. But it is something that if anyone's interested, I can send you his way for a consultation. So, I think we've come a long way in Las Vegas from 2 years ago offering essentially nothing to now with this program. I can steer you in the right direction for almost any type of operation. And the one that almost everybody asks about is, bottom surgery. When are we doing bottom surgery? And yes, I am doing vaginoplasties and hopefully phalloplasties by the summer. Let's see what we got here. As far as procedures for non-binary patients, it really depends. That's kind of those operations are tailored to the patient. So, some patients who are non-binary want, a chest surgery that makes their chest look kind of ambiguous, whether, slightly masculine but slightly feminine, depending on the attire that they're wearing. Some patients simply want their chest masculinization, some want feminization. So as far as the non-binary, I'm certainly willing to discuss and offer those surgeries depending on what they want. I will say that sometimes the insurance company is not as easy to work with the non-binary patients because, this is gender surgery is a very new thing, not only for the hospitals, but for the insurance companies. So, they're trying to figure out where do we even fit the non-binary patients into our, healthcare program. And so, all the surgeries right now that are done through insurance are set up for transgender patients. So sometimes it's a little trickier with a non-binary trying to get that covered by insurance. I have a feeling in several years this will all change, and in the future it'll all be covered without any questions asked. more hoops for the patients that identify as non-binary, only because the insurance is not really set up for that patient population yet, but we'll get there. So my background and experience, kind of talked about that already. I do, reconstruction head to toe. That's always trauma and cancer has been kind of my niche up until in the last several years. And I also do microsurgery. So, I'm on call right now for finger reattachments, limb reattachments at UMC. And I do free tissue transfer, which is a requirement for phalloplasty in certain operations in gender surgery. So I do have a background in those type of procedures. So that's why I think that I would be a good fit to do gender surgery. All right, so that's about myself. And then there's some questions on getting ready. So how can people get information about patient satisfaction, any lawsuits, and then photos of previous patients and results? So great questions. As far as patient satisfaction, there's almost all doctors now, if you Google our names, you go on the internet, there's WebMD, Vitals, Doximity. That's the best way to get an unbiased, assessment of how your patients think this doctor is. If you go to specific websites that are created by the doctor, oftentimes those reviews are tailored and they're modified, or the bad reviews are left out. So honestly, the best way to get an honest review is not to go on our specific websites, but to actually just Google and see what Google says, see what Vitals and Doximity say about us and our patient satisfaction. One thing that I have to say is that, I would say most of the patients, they know about me through social media and through connections within the LGBTQ community. So your best bet is to ask your friends, associates, people that that have had surgery from me, because I would say that half my patients that come in for surgery, they know somebody who had surgery and have seen my scars, have seen the photographs, and so they kind of know what to expect already and know a little bit about me. I've been busy enough. I do about 100 top surgeries a year. I did 5 gender surgeries this past week, 2 trans males on Monday, 2 trans women on Tuesday, and a vaginoplasty on Thursday. And so I'm doing these in high volume. So I have enough patients who are post-op in the community that almost everybody that comes to me has already kind of heard about me through them. So that's probably your best way to get your patient satisfaction, is to go through those avenues. As far as lawsuits, fortunately, I have not been sued yet, knock on wood. I've not settled any lawsuits or anything like that. But this is America, and they say that the average plastic surgeon has a 99% chance of being sued during their career. So it's only a matter of time. Lawsuits don't necessarily make a bad doctor. You can get sued for anything. That's one of the beauties and problems with America. So if you're trying to look for a surgeon or a doctor to see, a lawsuit here or there, probably not a big deal. It's going to happen to all of us if we practice long enough. It's the ones that have a pattern of lots of lawsuits. Then you have to wonder, well, this is not maybe an isolated event. Maybe this doctor has some red flags. All of that is public record, I believe. I think the Nevada Board of Medicine, basically, if you contact them, you can, I think, get all of the information on if a doctor's ever been sued or settled out of court. I don't think if you Google it, it comes up right away. So you kind of have to do some digging for that. But fortunately, to date, I've not been sued or had to settle anything in court. But again, if I do this long enough, I probably will. So as far as photos of patients and results, now this is, again, you really want to see pictures of what you're going to get. A lot of the patients come to me and they say, yeah, I don't care about scars. I don't care about how it looks. And so for most patients, it really probably isn't that important, but a lot of them do want to see before and after pictures. Unfortunately, because I work for UNLV, and this is the case for almost all academic university surgeons, they won't let me have before and afters on my website. Years ago, they told us that it was pornographic to have these things on a university website. So to me, I mean, this is crazy. They're not even allowing us to show, cosmetic surgery before and after. So I've been struggling with UNLV to try to allow us to have before and afters online, so that way patients can access this from the comfort of their own homes. And I have many patients who have already told me and signed waivers saying that they're willing to let me show pictures. But unfortunately, there's no good website. So what I usually do is patients who are interested in before and afters, I'm going to show you guys some today from a lecture. And then when patients come into the office, what I usually do is just break out my laptop and just show them pictures of my old patients. the best way to do it for me and with the limitations and restrictions that I have. So hopefully you'll get an idea from today's images of what the before and afters typically are. And then, if you come in for consultation, I'll be able to, and it is something that you want to see. I can certainly show you pictures just on my own laptop from my patients. Again, not ideal, but that's kind of how we're dealing with. All right. Can we talk about some techniques you use to get better results for shaved nipples, scarring, loose skin, drains, etc.? So my technique has evolved over the past several years. So if we talk simply about top surgery for trans men, the double incision mastectomy, I've changed the shape of the nipples. I started doing them circular and placing them kind of in the middle of the chest. And as I saw my results heal over the years, I realized that I like the nipples to be oval and a little bit more to the side. As far as scarring and extra skin, with experience, since I do, maybe about 100 of these top surgeries a year, I realize how much skin I can take away without running the risk of the wound splitting open, but at the same time, not leaving too much skin, because that's really what you don't want to make that mistake is leave too much skin during a mastectomy. It's really hard to fix after the fact. And so with experience, I'm able to do my markings preoperatively and plan exactly how much skin I think I can safely remove. And it's different on a case-by-case basis. Some patients who do binding for many years, their skin isn't as stretchy, so I have to account for that. So that's where the artistry of plastic surgery kind of comes into place. I try not to connect the scars in the middle if I can avoid it. Sometimes it's unavoidable if the breast tissue is essentially touching in the middle. As far as the getting the best scar, there's scar massages, scar creams, those kind of thing. But for me, the biggest thing is hiding that scar under the pec muscle. I've seen work from other surgeons who like to put that scar right in the middle of the chest, like they would be doing for a mastectomy on a cis female for cancer. And then the patients look like a cancer patient. Oftentimes they have to put the nipple right in the middle of the scar and it looks really bad. So I try to hide all of my scars for the trans men under the pec muscle. It falls into a natural shadow. So it's not as readily noticeable if it heals well. The drains. So I stopped using drains for my top surgeries. They did a study out of Southern California that showed that whether you use drains or don't use drains, it has no effect on the final outcome of the mastectomy. So the only time I use the drains for the keyhole, but for 9 out of 10 surgeries where I'm doing the double incision mastectomy with a nipple graft, I do not use drains. And so that's a huge advantage to the patients. They're so annoying. They hurt when they come out. And so occasionally we'll see a patient who has a fluid collection under their skin after surgery, and oftentimes I'll just suck it out with a needle in the office rather than put them through the drains. And that's not even the majority of the time. So I've abandoned using drains altogether. Patients love that when they hear that. I used to use drains early in my career, but now the evidence shows that we don't need them. So I don't put my patients through that anymore. Let's see, nipples, like we talked about those, drains, loose skin, sensation. For most of the double incision mastectomies, there's going to be sensation that comes back to the skin and the nipple as well. It's not usually the same sensation as they had before. It's not like an erogenous or sexual sensation that the nipple gets. It's almost like what we call protective sensation, meaning if you close your eyes and someone touched your nipple, you say, yeah, you're touching my chest, but it just feels like anywhere else on my chest, not like special, like nipple sensation. When I do the keyhole procedure, also known as the peri-areolar technique, that actually will maintain sensation to the nipple. And so those patients often will have similar sensation after surgery than before. Not always, but sometimes. Unfortunately, that's just kind of the price you pay if you have larger chest and you have to have a nipple graft. Sensation is often lost. But I will say that the majority of patients don't really care about that. And as far as the trans women, what I do is I essentially do the same operation for breast augmentation that I would do on a cis female, but there's some subtle differences. Number one, the nipples are typically spaced wider on the trans women, and so I have to center that implant under the nipple. If you put the implants together, then the nipples point out, and it looks really bad. So what I do is I try to center the implants as much as possible under the nipple, and you'll see in some of my photographs, it does make the implants space out a little bit more than they would on a cis female. However, if the patient really wants cleavage, cleavage is all about the bra. So I tell the patients, look, if you want cleavage, get a good push-up bra. I mean, even if I had a good push-up bra, I could have good cleavage. So cleavage is all about the bra. So that's one difference, is centering the implant under the nipple. One other thing I realize is that most of the trans women, the nipple is lower on the chest. that can be a problem then if you're trying to center that implant under the nipple. You almost have to lower what we call the inframammary fold, and I'll show you that in pictures here. That's that little crease under your breast, and sometimes that's tricky to do. So you'll see kind of how I address that in some of the pictures here, and how I still try to get a good result despite those limitations. I almost always have to go under the muscle unless the patient has significant breast growth from the hormone. Some patients actually will get breast growth, and some of the heavier patients will have a decent sized breast before surgery. Occasionally, I'll have that patient, I can put the implant on top of the muscle, but the majority of patients, they just don't have enough breast tissue to camouflage that implant, so we have to slide it under the muscle. When it comes to breast augmentation, there's several different approaches to the incision. Some surgeons do it in the armpit, some surgeons do it around the nipple. I do all of my incisions under the breast, in the breast fold. That's probably what 80% of plastic surgeons use for all comers, for trans and cis patients. The reason I do that one and not the other ones is that it's very well hidden underneath the breast. It allows you the leeway to make that incision bigger if I have to get better exposure, if I can't, see what I need to see. And it's the cleanest way to do it, meaning there's a less chance of contamination of the implant, infection of the implant, which can lead to long-term problems. If you go through the armpit, again, that's a dirty area. The advantage is it's a nice scar in your armpit and away from your chest, but it doesn't give you as much exposure. You're going through a dirty body part, putting an implant through a dirty body part, and there's a good chance you could contaminate the implant doing that. And then same thing with around the nipple. So some people like it around the nipple and incision around the nipple. The downside is if you scar very poorly, your scar will look very bad and it's right in the center of your breast. Whereas if you're scarred very poorly and you're under the breast, well, you can't really see that unless you lift your breast up and show people your scars. So, and then the other thing is the nipple themselves actually is not sterile. The milk or any of the fluid that your body produces internally has bacteria in it. So if I'm making a cut through that nipple, I'm potentially contaminating the implant that goes in through that nipple and can set you up for long-term problems. So some patients come in and they request a specific incision, and when that happens, I say, well, you're probably better going off to another doctor who does those other incisions, since I only do the inframammary fold incision. And the overwhelming majority of patients are happy with that incision. Also, if you need a revision surgeries require typically a bigger incision. And if you're on the nipple or in the armpit, you can't really get the exposure you need to do a lot of the revision work. So then you're buying yourself a cut under your breast anyways. And so then rather than having multiple cuts on patients, I always go right to the inframammary fold, the crease, and then do all my surgeries and revision surgeries through that as well. So that's the trans women. Those are questions about that. Okay. So do I have any requirements around weight, smoking, medications, or health issues? So let's start with the health issues. So really, most of my patients, fortunately, are young and healthy, or even if they're older, they're relatively healthy. So if there's any concern that they're not fit for surgery, I'll send them to the primary care doctor or the heart doctor, whoever they're seeing. And if they get permission, for surgery, then we can go ahead with it. As far as medications for genital surgeries, we do have the patient stop the hormones for about 3 weeks before surgery for the trans women. For top surgeries, I don't really recommend it. Those surgeries are very quick comparatively, so the risks of being on hormones are not as great. And so I don't typically require patients to stop the hormones before the top surgeries. As far as smoking, it's absolutely critical that you avoid smoking for anything that we do, whether it's breast augmentation, mastectomy, or genital surgery. Smoking will cause complications, and so the reason that smoking is bad is not so much the smoke itself; it's the nicotine. Nicotine constricts blood vessels, and when blood vessels constrict, so say you have a cigarette for the next 90 minutes. The nicotine has constricted all the blood vessels to your skin. So now the nutrients, the oxygen, everything you need to basically heal an incision or a wound is now, you're not getting that to that tissue. So if you're smoking a half a pack a day, that means all of your waking hours of the day, you're not getting enough blood flow to the area, and that sets you up for infections. The wound splits open. It gives you a terrible cosmetic result. That's how patients lose their nipple grafts. So smoking is critical to avoid 6 weeks before and 6 weeks after. So that's something that, if you're a heavy smoker, you should go to your primary care doctor and try to get on Chantix or something to quit ahead of time. I have last minute patients trying to go cold turkey, and that's not always the easiest thing to do. And then some patients will say, well, I'll just use the patch or the gum. Well, that's still nicotine, so you really can't do that either. So it's get the nicotine out of your system for 6 weeks before, 6 weeks after. And if you're able to quit smoking for 3 months, you should probably quit forever after that too. So as your doctor, you have to plug that. It's probably better for your long-term health because smoking will kill you if you keep doing it. Requirements for weight. So for top surgery, no, I do not have requirements for weight. Again, those are shorter surgeries, typically a lot safer. For genital surgeries, I do have a weight requirement. Really, it's a BMI cutoff of under 35. So for my height, I'm 6 feet tall. That would be 220 pounds or less. So for a lot of the trans women, they're going to be just under 6 feet. So you want to be probably around 200 pounds or less. And same thing for the trans males. So that's something that is very critical that you lose that weight. The complication rates go up substantially if you're overweight. The surgeries are much harder to do. So if you can get yourself to that goal weight now and come into surgery ready to go, that would be ideal. But we do have a strict weight cutoff for the bottom surgeries, and it's a safety issue. Cost. So what about the cost of these procedures? So fortunately, I would say 95% of these operations, top and bottom surgery, are being covered by insurance. There are a couple insurance providers here in town. Teachers Health, I believe, is one of them that doesn't cover gender surgery. There may be one other one. Some of them give us a hard time, but we can usually get around it and get it covered. So almost all of this is covered by the insurance. Now, when it comes to your deductibles, out-of-pocket expenses, you really have to contact your insurance company, and they'll tell you, what percent of your, surgery are you responsible for. So I can't tell you, globally how much does this cost out of pocket, because I know Medicaid, typically there's no out-of-pocket costs. Whereas for some of the other commercial insurance like Blue Cross or HPN, there may be deductibles, copays, those kind of things. And so it's best to contact your insurance provider ahead of time. We can help you out sometimes the insurance company says, oh, you got to give us the codes. The codes are just the codes for surgery, and we can email them and get you guys the codes so that when you contact the insurance company, they can say, okay, well, this is how much to expect to pay out of pocket. There are some costs that are often burdensome to the patients that are not covered by insurance. And that would be usually the laser hair removal. So for phalloplasty and vaginoplasty, we do strongly recommend laser hair removal. For phalloplasty, especially if you want to elongate the urethra, it's critical to remove the hair on the forearm or the thigh where the urethra will be, because you can actually get kidney stones or phallus stones within that urethral tract if you have hair there. And as far as the vaginoplasty, if you don't do the hair removal beforehand, you'll basically have hair on places that a cis female maybe wouldn't have hair, particularly on the labia minora, and then on the lining on the inside of the vagina. So it usually doesn't cause major functional problems to have hair there, but it can be, it can look a little abnormal if there's hair in places that typically you won't see. So what I tell the patients is, we don't have a hair removal device in our office. I'm hoping to get it one day and make things a lot easier. But I do have a group of trans-friendly electrolysis salons, as well as laser hair removal. So I have a list in my office. If anyone's interested, you can get that from my office. And what I tell patients is keep your receipts. And then what I try to do is after surgery is I'll send the receipts with a letter from me, basically saying, why this is medically necessary. And I send to the insurance company with that letter and say, hey, can we reimburse this patient for these costs? And from what I've heard around the country, this is not specific to Nevada, but around the country, about half the time you'll get reimbursed, and the other half of the time, the insurance company says, hey, that's laser hair removal, that's on you. Again, I'm trying to do my best to pass legislation here in Nevada that forces the insurance company to pay for hair removal, because, to me, it's not cosmetic. This is a functional thing. But the minute you say hair removal to an insurance company, they just say no. So that's something that we're still working on. And another thing, as far as costs are concerned, is most of the revision surgeries for the trans men, the mastectomies, most of the time I can get any revisions covered by insurance. And so that it does not have to pay out of pocket typically, other than your copay or your deductible. For the trans women, breast augmentation, that's one where it's a little bit trickier. Insurance companies will often pay for one breast augmentation, chest feminization surgery. But if you have a complication, not necessarily a complication, but if you have a result that you don't like, or say you want to be a larger, or say you have what's called capsular contracture and you develop scar tissue around one of the implants. As it stands right now, I'm having a hard time getting the insurance to reimburse for revision surgeries like that. So you may have line if you need a revision surgery. Well, I'm working on legislation to get revision surgeries covered. The way I look at it is if you have breast cancer and you have, basically breast reconstruction with implants, and then you need a revision in the future, that's covered by insurance. So if it's medically necessary for a trans woman to have or breast augmentation, and she has an issue in the future that requires a revision, by the same logic, I would think that should be covered. So I'm trying to get the insurance companies to cover these things. Insurance companies are not in the business of offering more to their customers, and so it's still a struggle. I have a feeling in the next 5 to 10 years, though, the revisions will be paid for. So if you have your surgery now and you need a revision in 10 years, there's a good chance that insurance will be covering that at that time. If you need a revision in the next year or two, I can't make any promises there. That'll often come out of pocket for the patients. But the good news is that the overwhelming majority of the insurance companies are paying for at least that one chest feminization surgery. As far as genital surgery, same thing. Most of the time, if there's going to be a revision, there's a medical reason for it. And so, whether it's scar tissue pain, something, the insurance companies will pay for revisions for that as well. So most of the revisions don't come with a substantial cost. And then how does somebody get started? Basically, blood work, testing, referrals. So in order for not only the insurance to pay for some of these procedures, but in order for me to meet my requirements for the WPATH, the WPATH is the World Professional Association for Transgender Health. The current WPATH standards, which I follow, are 2 letters for bottom surgery and 1 letter for top surgery. The new guidelines will probably come out in a year or two, and the word on the street is that they will probably be less aggressive in terms of letters, and so potentially top surgeries can be performed without letters, as long as the surgeon and you agree that it's the right operation. Bottom surgeries will probably require letters for some time. So in order to get your surgery, you are going to need a letter. So I don't necessarily need your letter before you see me. However, we can't do your surgery until we get your letters. So I've compiled a list of mental health professionals here in town who are willing to see the transgender patients, and they know exactly what these letters are. And if you ask for them, the majority of them will be happy to meet you, and in one consultation, basically, and if you're a very reasonable, straightforward patient, they'll be willing to give you your letter based on one evaluation. I know there were some people in town that want to see you for 6 months or something like that, but I've kind of found a group of people who, mental health professionals who are very trans friendly, who can typically, if everything makes sense, write your letter in one sitting. So if you want to get your letters ahead of time, that will speed the process up. I would say most of the patients show up to my office already have at least 1 letter from a mental health professional. So that will speed the process up. If you don't have them by the time you see me, not the end of the world, but I'm going to say, all right, well, here's my list, go get your letter, and we'll book your surgery after we got your letter. So that's usually the thing that holds people up the most, is getting that letter. As far as blood work, testing, there's very little testing that typically needs to be done beforehand. Blood work, most patients that require general anesthesia will get routine blood work, and that's right before the surgery, usually within 30 days of the surgery, they need that blood work. So that's all done through our office. You don't have to get that ahead of time or out of the way or anything like that. That'll all come as part of the operative experience. So really, it's just the letters is the main thing. Let's see here. We talked about cost a little bit, and then getting in to see me. So yeah, and then also getting in to see me. So the best way to find me is to just set an appointment up with my office. My office number is 671-5110. And then my scheduler is Heather Roberts, and I believe her email is Heather, that's HEATHER Roberts, ROBERTS @unlv.edu. So it's the common spelling there, heather.roberts @unlv.edu. She's my surgery scheduler, and she is familiar with this whole process. So if you email her, she can often reach out to you, get you ready for anything you may need before the consultation, and then schedule a consultation with me as well. So that's the best way to get a hold of them. Or you can call directly, but sometimes with the call center, it's hit or miss whether that gets passed along to our office. And so if you try calling and you don't get a response within a day or two, just go ahead and email my scheduler, and she can get you in with me right away. All right. The day of surgery. So now we've got we've gotten through the approval process. Your insurance is paying for it. I've examined you. We've agreed on an operation. Let's talk about what the experience is like. So, people always ask who's going to be in the operating room with me. And so it depends on the surgery. So for top surgeries, it's usually me and one of my trainees. And so I am the director of the UNLV residency program for plastic surgery. So I have 6 doctors who work under me. They're all graduated from medical school and they're in various levels of their training. So it's a 6-year training program. The ones that are assisting me are typically in the later years. Oftentimes it's the senior resident who is the 6-year doctor. And they're usually months away from going out and practicing on their own. So they're usually the ones assisting me. I'm the one doing the operation. They're my assistants. I'm there the entire operation. Any part of the operation that I allow them to do, I'm guiding them through it. I'm telling them exactly what to do. So they may be in the operation helping with it, but I'm the one doing the surgery. There's not medical students practicing on anybody or anything like that. They practice in the lab on rats and on pig skin and that kind of a thing. But there may be medical students observing. I do work for UNLV School of Medicine, and so for some of the bigger surgeries, the genital surgeries, we'll typically have 1 or 2 medical students there observing. As far as the chest surgeries, most of them are done at surgery centers, and even the ones that are done at the hospital, there's usually not a medical student. So in the operating room, when you get wheeled into the room, you'll find myself in there, the anesthesiologist, there's a nurse who's helping out in the room, a technician who basically gets the room ready and hands the instruments, who will be there assisting me. And then you'll usually meet one of my trainees who assists me, and usually meet them beforehand as well. And then potentially a medical student observing. So that'll be who you meet in the room. And then, like I said, the medical students are not going to be taking part in the surgery. The only one taking part in the surgery will be myself. And then some of my trainees who are in their higher level of training, I may let them do some of the operation while I'm watching them, telling them what to do. But really, I'm the surgeon. It's my license that's on the line, and they're my patients. So I take complete responsibility of everything that happens in that operating room, and I don't leave the operating room. So like I said, then that answers kind of the next question: what level of experience will they have? They've usually at least had several years of training in plastic surgery, and most of them, if I'm letting them do any of the actual operation, they're usually ready right before graduation. What does a surgery typically look like or involve? So again, we can just talk about these based on top surgery versus bottom surgery. So top surgery, most of these are pretty quick operations, whether it's breast augmentation, chest feminization, or chest masculinization, 1.5 to 2 hours for the whole operation. Typically, they do not require catheters in their bladder. Intubation and general anesthesia is required for them. And for both of those, you'll wake up basically in the recovery room and spend an hour or 2 in the recovery room waking up. So for top surgery, it usually ends up taking about a half of your day. You got to get to the hospital or the surgery center, check in, do the surgery, recover for a couple hours, then you go home. So those are pretty quick, in and out of the hospital, in and out of the surgery center. In terms of genital surgery, that's a big difference. So genital surgery, those are long surgeries. The vaginoplasties and the vulvoplasties take between 6.5, well, actually yesterday's was about 4.5, anywhere from 4.5 hours to about 8.5 hours to do those operations. So again, under general anesthesia, that certainly requires intubation. So we have a machine that breathes for you. You're asleep the entire time. Those patients do require more tubes and drains and catheters when they wake up. But for top surgeries, you wake up with no tubes, no drains. You have an ACE wrap around your chest and you go home, and that's it. Genital surgery, when they wake up, we send them to the inpatient side of the hospital, and they spend about 6 days in the hospital. So I do almost all my vaginoplasties and vulvoplasties and pretty soon phalloplasties on Thursdays, and then they usually get discharged the following Wednesday for the full depth vaginoplasty. For a 0 depth vaginoplasty, usually we can discharge them on Monday. So you end up spending anywhere from 4 to 6 days in the hospital after a vaginoplasty. We're very good about maintaining pain control when you're admitted to the hospital. They all go to the same nurses station basically in the hospital, where they have private rooms. So I've never had a patient had to share a room after a gender surgery and deal with a roommate. The nurses are all very good about and very affirming to my patients. I've actually gone and met a lot of them at the hospital personally, kind of explained to them how to address patients, how to care for patients. There is one caveat, and this is something that I don't think I'll ever break the habit of these nurses. We have a lot of Filipino nurses at UMC. And so in the Filipino language, they really don't way, like him, her, they, them. So, I mean, half the time they call me her. So don't be offended if some of the Filipino nurses misgender you. Their brain just does not think like that with pronouns. So I'll have, a couple of patients say to me afterwards, you keep calling me the wrong gender. And I said, look, they call me the wrong gender too half the time. So as much as I try to train them, they're not out trying to be malicious. They're very good nurses and they're very affirming. There's just a language barrier for some of them. So again, there's nobody in these specific units that's going to be offensive to the patients. And most of the patients are very comfortable. For the vaginoplasties, we put them on a controlled narcotic. So the patient actually has a little button, they can give themselves a dose of pain meds throughout the hour rather than wait for the nurses. And most of the patients are up walking around, shuffling around the room on post-op day 1. And so they stay there basically because I do have to pack the new vagina with gauze, and I don't want them to go home with that. So they stay with that, till that Wednesday, and we take all the dressings down together in the hospital. So that's a very different experience to have bottom surgery than top surgery. So that's in the hospital care. So let's talk a little bit about post-op. So, well, let's see, or complications. Let's talk about complications. So every surgery has risks. Even if I'm just taking a mole off somebody's cheek, they can get infected, it could bleed. So for top surgery, the real risk we worry about is bleeding. And about 3% of the time, so that's 3 out of 100 or 1 out of 30 times after a top surgery, particularly the mastectomies, a patient will have a bleeding problem. And how does that present? So the patient will wake up in the middle of the night, usually the day of surgery, and look down, and they'll have swelling on one side or the other. And that's because blood is building up under the skin. So then we got to bring the patient to the ER, bring them to the operating room, fish out the blood clot, and then stitch them back up. So it doesn't have any long-term effect on the result, but it is scary to have to go for emergency surgery in the middle of the night, and everything. So it's very rare. Like I said, 1 out of 30 patients will have this problem, but it is scary when it happens for the patient. So I do want to let you know ahead of time that this is a risk. It's a low risk, but certainly a risk. Other things like bleeding, infections are very rare after top surgery. The one thing that we see the most common would be fluid collections, and that's just sterile fluid that builds up underneath the skin. And I would say that's maybe 10% of the time. And then all I do is in the office, when they come in for their follow-up, is I just suck it out with a needle. Takes about 2 minutes, and it's usually pain-free. I can usually go through an area of the skin that's numb, and if the skin isn't numb in that area, then I just give a little numbing medicine, and then that's a lot easier than dealing with the drain. And drains actually haven't been shown to even prevent that. So that's a pretty common thing that we see, and again, it's a very easy fix. And insurance will pay for any of those. If you have to go to the emergency room in the middle of the night and go to the, back to surgery for bleeding after a top surgery, if insurance paid for the original surgery, then they'll pay for that emergency as well. As far as bottom surgery, a lot more chance for complications. So, the list can go, I could give a whole talk on the different complications for vaginoplasty. But just in a nutshell, same thing. There's always that risk of bleeding. Fortunately, I haven't run into that yet. Infection is pretty uncommon, to be honest with you. The things that we see most commonly would be wound healing problems, meaning that the skin doesn't heal quite right because it's a dirty area of the body. It's a moving area. You're sitting on it. And so sometimes the wounds will open up and then they take a little bit longer to heal in. So that's a very common problem. Some of the more uncommon problems would be like the loss of the skin graft on the inside of the vagina. That requires prolonged wound care and can cause scar tissue to build up. Fortunately, that's pretty uncommon as well. The rarest complication, but the scariest one, is basically if there's any damage to the rectum when you're trying to create the vagina, and stool can actually come into the vagina. That happens about 1% of the time. So whether I do it or somebody who's done it 100 years in Belgium, that risk is always there. That the stool can actually enter the vagina, and that's a nightmare of a problem because not only is that unacceptable, but to fix that, oftentimes the patients will need a temporary colostomy, which is a bag in your abdomen that you kind of poop out of for up to a year until we fix the hole that's going between your vagina and your rectum. So fortunately, that's a 1% risk across the world, whether no matter who's doing it. But it's a huge thing to happen if it does happen. There's also urinary issues that could happen because we're shortening the urethra. There's always the possibility that you could have stricture, which is scarring of the urine, and that could require revision surgeries or issues in the future. Or the clitoris itself could lose sensation. They may not be able to have sex afterwards, for example, if they don't dilate. So there's things that can happen post-operatively for vaginoplasty. I'll go over some of those more common complications when I give you a talk, maybe at the center coming up here, or when you come in for your consultation as well. Same thing for phalloplasty. Much higher complication rates, kind of amongst the gender surgeons, we say for phalloplasty, a third of patients are going to have a stricture, which is scarring of the urethra, and it can actually affect the stream and can become an emergency, and the urine can back up. A third of patients will have a fistula, which is where the urine kind of shoots out of the side of the phallus, and then about a third of the patients will avoid all of those altogether and not have any urinary complication. So it's important to know that I would say the majority of patients will have some type of complication with the urinary stream. Again, whether it's me that does it or somebody that's been doing it for a long time, it's just that the nature of creating a structure that was not designed to carry urine. Your body wants to form scar tissue and cause nightmares for the surgeon and the patient. So, that's kind of the more common complications you'll see with phalloplasty. Certainly there's not as much nerve sensation that comes back. And so it's variable, how much sensation patients can get after a phalloplasty. Also the ability to have penetrative sex. So if you decide to have a prosthetic inserted after a year into the phalloplasty, now your complication rates, infections of the prosthetic, damage to the skin overlying the prosthetic, the long-term longevity of that device, if you're getting this at a young age, there's a good chance that at some point in your life that you could have a problem with that prosthetic if you're talking about decades of use. So again, just like vaginoplasty, phalloplasty has a substantial complication rate. And before we kind of jump into those operations, I have long discussions with patients about those complications so they know what they're getting into. And again, same thing with phalloplasty. As I start to offer those operations, any complication as a result of phalloplasty, which are inevitable, is paid for by the insurance company because there are medical problems. All right, and things to prevent them. Well, I do everything I can to stay up on the latest and greatest literature. I'm constantly critiquing my own technique. I'm learning from my own complications, how to prevent them in the future. And so even since 6 months ago, when I started doing the bottom surgeries, my technique has changed substantially in 6 months. Same thing with top surgeries. If I look at the top surgeries I was doing a year or 2 years ago, very different than the ones I'm doing now. So I'm kind of learning as I go and learning from my own mistakes. And that's just the nature of being a doctor. It's what they call the practice of medicine. All right, so typical recovery timeline. Again, we'll just lump this into top surgery and bottom surgery. For top surgery, almost all of those patients, I tell them 6 weeks is kind of the generic. Take 6 weeks off of heavy lifting, exercise. If your work is labor intensive, take that time off, and just kind of take it easy and wear some compression during that time. So during that time, the patients, I don't let them lift anything greater than 10 pounds. That's about the size of a small backpack or a large purse. If they're, like I said, if they're doing something for work that's labor intensive, I'll let them go back after a week or two if they can do light duty or a desk job. Most of the patients are off pain pills by a day or two, so they're not really an issue with driving. I do let the patients drive as soon as they're off pain pills. Usually that's within a day or two. Daily activities, yeah, just kind of stuff around the house to get yourself through the day. You should be fine for after top surgery. But as far as working, you want to stick to like 6 weeks before you're doing any real exercise. I tell patients, tell your employers for top surgery, if you do have a desk job, I still want to see you probably one time, make sure that you're good after surgery, usually a week after surgery, take a look at everything before I let you go to an office or something like that and actually go into work. But since everybody's working remotely, once you're off the pain pills and you're not, stoned on narcotics, then you could probably work virtually from home, almost immediately after surgery, at least for top surgery. So that's your typical recovery time. Those patients, you need a caregiver maybe just for a day, just when you're recovering from the anesthesia while that's wearing off. As far as a caregiver to help you out around the house, not necessarily. You should be able to drive and take care of yourself, bathe yourself. Some patients don't like doing their dressing changes on the nipples, so you may want to have a friend do that for you if you can't do that on your own. But as far as top surgery, most of those patients are very independent. Bottom surgery, again, very different. So like I said, they spend a week in the hospital almost. Their follow-up visits tend to be a little bit more often. For top surgery, I usually see the patients 1 week after surgery, then about 3 weeks after surgery, and then I will see them like 6 months or a year later for the long-term result. For genital surgery, it's a little bit different. So genital surgery, you're spending a week in the hospital. Then you see me basically like weekly for several weeks as we're watching the wounds heal. Those patients are not for vaginoplasty and phalloplasty. You're not allowed to sit for 3 weeks. So if you're in a car, you have to lay in the back seat or recline your seat. And then as far as work, most of the patients after the vaginoplasties have to dilate. So dilation is when you're essentially putting in, it's basically like a dildo, but it's a piece of plastic or rubber or silicone that basically holds open the vaginal canal for 20 minutes a pop. And so in the beginning after surgery, you're doing that 3 times a day. I don't cut you back into 2 times a day until 2 months out. So, that's when I tell patients you can probably go back to work after 2 months after a vaginoplasty, because you can sit at that point and you don't have to dilate 3 times a day. So you can dilate when you get up in the morning, you can dilate at night, and then you don't have to, like in the middle of the day, worry about where you're going to dilate. So I would say for most patients, you're probably taking 2 months off of work for vaginoplasty, and those patients will typically need someone to help them out at home, at least in the beginning days when they get home, because they're kind of just shuffling around the house, and they're still a little bit sore. So I do recommend having somebody to support them, at least be available to them, right after surgery when they go home. But fortunately, they stay with us for about 6 days, so we can help them out with a lot of that. Follow-ups, we talked about that, activities and time off work, and then driving. Okay, good. Aftercare that I recommend, and sleeping and supplies. There's really not a whole lot you need for aftercare. For the top surgery, for the trans men, for the mastectomies, we give you the gauze that you need for your dressing changes. And then I just use an ACE wrap for compression, so you don't have to buy anything special. For the breast augmentation patients, I tell them to buy a sports bra to recover in, and they wear that for 6 weeks. That's like their compression device. I do recommend getting one that either zips or snaps in the front, so that way you're not pulling like this big bra over your head while you have fresh incisions. Something that you can kind of pull together and snap in the front would be ideal. So I always tell the patients ahead of surgery, get yourself a sports bra. Target, Walmart, they have these kind of cheap ones that are gray, I believe, gray and black. And most of the patients come in with one of those, and that way if you get blood on it, it's not the end of the world. All right, sleep recommendations, whether it's top surgery or bottom surgery, probably for the first couple weeks after surgery, you kind of try to sleep on your back. So some patients are sleeping in a recliner, but I'll be honest with you, the pain will kind of limit you. So if you're rolling over in the middle of the night on a fresh incision, you'll say, ow, and then you'll roll back onto your back. And so by the time that pain is gone, usually you're recovered enough that you can start sleeping on your side. You don't want to sleep on your stomach for a few weeks, and probably a week or so before you're actually sleeping on your side. It's easier said than done, but most patients do just fine with sleeping afterwards, and it's not typically a burden for them. Revision surgeries, we kind of talked about that already. If this is something that you pay out of pocket, I do unfortunately have some patients where their insurance company doesn't pay for it. Any revision surgeries, most of the time it's an in-office thing that I can do and fix in the office, and I can get insurance to pay for those. And if it's something that you paid for, say you paid for your mastectomy and nipple grafts and you needed some revision in the office, I will waive any fees for that. So that's, you pay enough money to have the surgery. If there's some issue that you don't like, usually I can just fix that in the office and do that for free. I have not had to take any patient back for a revision that paid cash to the operating room. If that happens, typically I'll waive the surgeon's fee, so I don't get any money for that. But oftentimes the patient may be responsible for the anesthesiologist and the facility, and that would be the surgery center. So there may be some cost for revisions if you pay out of pocket, if we have to go back out to the operating room. But for almost all revisions, especially if it's covered by insurance, I can do them in the office, which would be free if you've already paid out of pocket. And if you went through insurance, I usually just bill the insurance company for those, and I can figure out a way to do that. So most of the revisions are done in the office. I would say that for top surgery, excuse me, revisions is about 10% of the time, and that's usually dog ears. And, anyone who's done any research in top surgery knows what dog ears are. It's that extra tissue you get under your armpit. Sometimes you can't remove that at the time of surgery. And so it's not that you have a bad surgeon, sometimes that dog ear goes all the way to your back. So if you're lying on your operating room table like this, flat, I can't always get to your back to get rid of that extra skin. So what I tell the patients is, let's just wait a year, 9 months to a year. Most of the time it flattens out on its own. And if it doesn't, well, then I can just numb them up and cut out that dog ear in the office and stitch them right up. And so I do that time patients will need that surgery. Sometimes the nipple is too prominent, in which case we can just amputate that, put 2 stitches in that in the office. If the pigment doesn't come back for your nipples, just send you to a tattoo artist, and oftentimes they can just color in, some of that pigment. So it's very uncommon to have to pay substantial amounts for revision surgeries. Like I said, most of the time I can get insurance to kind of pay for this. And then if you pay out of pocket, like I said, anything that I do for you is part of the original fee. If we do have to go back to the operating room, though, sometimes the anesthesiologist and the facility may charge money. But fortunately, has not been something that I've come across yet. But if we look at cosmetic surgery, for cyst patients, if I do like a breast augmentation and they need a revision in the future, I always waive my fee, and then they do have to pay for the operating room time, though, to use that facility. How soon after surgery will I see my final results? And so basically, I like to say for breast augmentation, even though the implants go in right away, it takes a long time for the soft tissue the swelling to go down and for the implants to drop down to get that final result. So I tell patients it really is about 6 months to get that final result, and that they look a little weird for a few months. And so don't even worry about how they look initially. They all drop given enough time with gravity, and they all tend to look a little bit more natural after about 6 months. Same thing with top surgery for trans men. They have a lot of swelling initially. The scar is usually very thick initially, very noticeable. Oftentimes it's pink, and oftentimes the nipples are pink. If you give that enough time, almost all of that fades away, and you'll see some pictures here coming up of what it looks like long term. Fortunately, the complications after top surgery don't affect the long-term outcome, and that would be like if you have a blood clot that we have to remove, it doesn't have any effect on the long-term result. Knock on wood, I've not ever lost a nipple graft, but I would imagine, if that happens, that would probably require some revision in the future. Although I have to say that I've seen nipples die on patients before from breast reconstruction, and then when that kind of heals in, the scar almost looks like a nipple graft would have looked like anyways. So oftentimes the easiest treatment for them is to tattoo your whole chest and just hide everything. So sometimes that's the way the nipple grafts look too. It's often unpredictable who's going to have an awesome looking nipple and who's going to look a little weird. And sometimes it has nothing to do with the surgery. It's really about the patient's anatomy and their DNA. And so, fortunately, tattooing is very prevalent nowadays and very mainstream. And so a lot of my patients end up getting tattoos all over their scars anyways. As far as bottom surgeries, again, complications they can affect the long-term result. For example, if the clitoris, if the nerves are not ideal and the nerves are damaged, you can have loss of sensation to the clitoris. If some of the skin on the inside of the vagina doesn't survive, that can cause the vagina to shrink down and maybe not allow dilation very readily. And sometimes that can require revision surgeries. And we talked about, the dreaded complication of the stool coming into the vagina and bowel movements and small amounts of stool coming into the vaginoplasty. So those certainly you can have long-term complications from vaginoplasty that I'd have to kind of go over with the patients individually, or I'll probably end up giving a bottom surgery talk for the center at some point where we can kind of go over all the complications and what typical results look like as well. And if you don't like the final result, like I said, sometimes for the most part, I can get insurance to pay for things if it seems like it's a reasonably medically necessary. I've even gotten some revisions from other surgeons paid for that were more cosmetic revisions. So it really depends on the insurance company. Sometimes I can get things, if say you just don't like the appearance alone, has nothing to do with pain or scarring or lumps or bumps. Sometimes that's tricky. The insurance company say, "Oh, that's cosmetic. We don't want to pay for that." But I figured out ways to kind of work with the insurance company to get that paid for. So it's kind of hit or miss. Gender surgery is a new thing for the insurance companies, and so I'm learning how to navigate the insurance system as well as the patients and the insurance companies too. This is new for them. How soon after surgery will I see my final results? So I guess like your first time you can actually see your chest is 2 days usually after the breast augmentation. That's not your final result, but they can actually look at their chest for the first time. And then same thing with the top surgery. I see them the next week after surgery, so they can actually see their chest for the first time a week after surgery, but it will take them a long time till they get that final result. Sometimes even up to a year. Same thing with the bottom surgery. They can look at themselves a week after surgery when we take the dressings down, but it's going to look swollen, bruised, the red, it's angry, look very different from the long-term results. So I'll show you some of the longer-term results. And then providing a letter. Yeah, so I've done some, fortunately Nevada is pretty easy to change your driver's license and birth certificate, I believe, but a lot of people have birth certificates from out of state. And so I've done this many times in the past. I'm happy to write a letter saying, basically the letter that they want is for me to say that I have performed an irreversible gender operation on you. And so if I've done that, I have no problem writing that letter. I've done that before for people who have, issues with birth certificates or driver's license from other states that need that documentation. So yeah, I'd be happy to provide that. And then the last question here before I show pictures is some counselors will not give letters because of their fear for being accountable if patients regret surgery. I mean, the surgical regret is so low. I mean, if you look at cosmetic surgery just in general, not trans surgery, but cosmetic surgery, up to a third of patients are unhappy and regret doing it. Transgender surgery is much, 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 much lower than that. So, anyone who says you shouldn't be doing gender surgery because patients may regret it, well, I turn around and say, well, maybe we shouldn't be doing cosmetic surgery because way more patients regret that. So that's kind of how I look at it. And fortunately, we have a lot more trans and non-binary friendly mental health professionals here in town that are willing to take that risk and sign on the dotted line and write your letters. So I have compiled that list for everybody. My office can give you that. My scheduler has that list. You can even email it to you of all the mental health professionals who are willing to basically write the letters. And so it did take a long time for me to find these mental health professionals, to find the ones that are not scared to write letters, to find ones that are very affirming. But I do have a core group of mental health professionals that I can refer to that I really rely on for that. And so, yeah, unfortunately, I'm not there with you today to answer any other questions. I'd love to come in and give a talk some night when we're in person and go over all of that, of your own questions. But what I'd like to do right now for the next few minutes is I'm going to pull up a talk I gave for medical professionals, but it'll show you some befores and afters of my typical top surgeries. And then I have 3 examples of some of my post-op vaginoplasties. So you can see what they typically look like early after healing. Now, remember, I've only been doing these for 6 months, so I don't have like year follow-ups. These patients are still kind of in the process of healing and will look a little different long-term. But this will at least give you an idea if you're wondering, what is Dr. Brosious going to do to my genitals? This will give you an idea of what the vaginoplasties look like. And then hopefully, as I start performing phalloplasties, we'll have patients who are willing to share those images as well. So I'm going to go ahead now and share my screen. And we can look at some of our results. All right. So right now I'm sharing my screen, and I first want to show a few slides on top surgery for men. So again, these are medical pictures. So there are some maybe open wounds and stitches. So anybody who's queasy with stitches, open wounds, that kind of a thing may want to turn away right now. So this is an example of a trans male. This is typically what you'll see, kind of the deflated appearance of the breast from binding. And the operation that I do is basically I decide how much skin I can remove safely, and then try to hide those scars basically under the pec muscle. So, when you have a muscular patient like this, almost anything you do is going to look good. But you can see with my technique, what I try to do is hide that scar under the pec muscle, make the nipples oval, put them kind of down and out, and really camouflage that scar where you would have a natural fold in your body. Again, these are all my patients. These are all surgeries that I performed myself. These are not like pictures I've stolen from the internet or anything like that. This next patient here, kind of the opposite end of the spectrum, very large chest. You can see, the damage from the breast binding, but the technique is really no different. Estimate how much skin I can remove safely. And this patient, I told him right off the bat, your chest is way too big. I can't separate the scars. Your scar is going to have to cross the midline. So on his final result here, and he's still kind of healing, but you can see that scar is hidden kind of under the pec muscle here. And the nipples, again, more oval and kind of spaced widely. And the reason that there's a significant amount of tissue issue is if you look at his build, he's a heavier guy, right? So I'm not going to do like a cancer operation, like a cancer mastectomy, and skeletonize his chest and look very abnormal if he has a belly, right? So that's why I kind of do this operation where I leave a little tissue so it looks very natural. It's proportioned to the top and the bottom there. Another example of a patient kind of in between these two with larger breasts, but again, when I met this guy, I said, look, your folds underneath your chest, you're touching the middle almost. So there's no way around it. That scar has to cross the midline. again, estimate how much skin I can. And then here's kind of a post-op result there. Still healing. This is an example of that nipple loss of that nipple coloration. But what I try to do is when I make these scars connect, rather than going straight across the chest, which looks very abnormal, the pec muscle itself is like a fan shaped, and so it's kind of rounded here. And so what I do is I curve that incision up on both sides, so it looks like a seagull or a bird in flight, rather than going straight across. And I would say that about a third of patients need to actually get that incision to touch in the middle. Most of the time, I can keep them separate. Very rarely you'll get a patient like this who has very small chest, no extra skin, and good skin elasticity, meaning that I don't think this person's going to have a bag of skin if I just remove the tissue alone and no extra skin. So for him, what I do is I do basically make a cut around the nipple. So some people call this the keyhole approach. Um, the reason why the keyhole approach is actually not the right name for this is because the keyhole technically refers to a technique where you cut all the way around the nipple and then make another cut all the way down to the fold. And so it looks like a lollipop, or almost like if you put your key in a lock and turned it. That's what a keyhole is. However, in gender surgery, there's kind of this concept that we consider any minimally invasive technique like a keyhole surgery. And so what I do is basically cut from here to here, from 3 o'clock, if you think of this as a clock, from 3 o'clock to 9 o'clock, and then I remove the whole entire breast tissue through that incision. And then what I do is I do liposuction around the edges here to smooth it out so that it's not like someone took a chunk out of this person's chest. And so that, some people will call that the keyhole. The original keyhole, I do not do that operation. And the original keyhole is actually a modification of a breast reduction. And that does leave a scar around the nipple, 360 degrees, and then a scar that goes down. And then the breast often looks like a breast after surgery because it maintains some breast tissue to preserve the nipple sensation. So the patients don't want that. If you want a masculine chest, you don't want to have breast tissue behind just to preserve the nipple sensation. So the more I learned about the trans men and their goals, very few of them really care about what their nipples feel like. So at the expense of controlling the scar tissue and the contour, I avoid doing the keyhole now. So what some people call the keyhole, I will do, which is basically make a cut around the nipple. But I call that the peri-areolar, meaning around the nipple technique. And this is what he looked like afterwards. You can see he's still kind of healing from the surgery. But this is a nice technique in that you don't have big scars anywhere, just little scars kind of hidden in his nipples here. You can kind of see where the little tiny poke marks were for the liposuction here and here. And with time, those will fade away. And then you can get a good result without those big scars. But again, patients can't come in saying, I want the keyhole operation, because it's really not what you want, it's what your anatomy allows. If I do a keyhole operation on the other patients I showed you, they would have a bag of skin, like a sock of skin. That would look terrible. And that's hard to fix after the fact. So you have to kind of let me use my judgment. If you don't look like this patient with very tiny breasts and no extra skin, you can't get a keyhole and expect it to look like this. It'll look like, you look like you have a deflated sock, like out of the laundry hanging off your chest. It'll look terrible. So sometimes you have to trust my judgment. The scars are bad. I'll give you that. With the double incision mastectomy, they are big and they are noticeable, but it's certainly a better trade-off than having a bad contour afterwards that often you can't fix. Here's another example of patient, same idea, very small breasts, no extra skin, and you can get away with basically cutting around the nipple and then taking out all the breast tissue through that little incision. You can see, he's healed up nicely. Hardly see those scars. Those will fade even further with time, but a good result without having to make that big incision. Some people ask me, well, what about the nipple location? The one downside to this technique is that you can't really change where the nipple is. Wherever the skin heals back down, that's where the nipple has to stay. You can't move the nipple at all. And so, some patients say, I really don't want my nipple in the middle of my chest. The only way to do that then is to do the double incision mastectomy, where I make that scar under the chest and then I put the nipple on wherever I want as a graft. And for him, I would put it in a different location, a little bit lower. But that's the trade-off, is that I can't move the nipple in this operation. So that's why each patient, we talk about your goals. Say this patient comes in and says, I don't want my nipples to be in the middle of my chest. I don't like that. I may have to talk this patient into doing a totally different operation and say, all right, well, to achieve those goals, maybe we need to do the big incision mastectomy, and I'll just take your nipple off completely and put it down and out. So I kind of have to tailor that to the patient, but you have to let me use my experience. The patients that come in dictating, this is the operation that I'm going to get. Oftentimes, if the surgeons let patients talk them into doing the wrong surgery, everybody's unhappy. The surgeon's unhappy, the patient's unhappy, nobody wins. So you can certainly have your goals in what you want, but your anatomy limits what you can actually have. And so that's what I'm here to be, the one that gives you the realistic expectations. I don't want to sugarcoat anything. So let's switch gears a little bit. Those are for the trans men. Let's talk about chest feminization surgery. So this is different. This is breast augmentation. And so this is one of my patients. And so what you'll notice is that these patients, she actually has quite a bit of breast tissue, but oftentimes my patients won't have a lot of breast tissue. And what you'll notice that the nipples are spaced a little bit more widely than in a cis female, and that there's not often a lot of tissue between the nipple and the fold. And so oftentimes I have to lower this fold, which is not easy to do. This is like an anatomic structure that doesn't want to go away. It's like a bad X that will just never leave you alone. It'll stay there. Even after surgery, you try to fix that. And you'll see examples of how I try to get rid of that. So the incision that I use, like I said, is in the fold here. And I basically put these implants almost always under the muscle. So this is her after surgery with a very natural result. You can see that the implants are centered under the nipple so that they're not like, the nipples aren't like pointing out. And then you can't even see her scars, you know, they're hidden in the fold there. But if you look at her mole, we had to lower that fold substantially to accommodate that implant. If I didn't do that, and I just put these implants in, this implant would be sitting on her shoulder up here and look very weird, and her nipple will be on the bottom of the implant. So I basically had to lower the entire breast, where the breast is located on the chest, lower it significantly to accommodate that implant. And then on the lateral view, you can kind of see the same thing. Not a lot of distance between here and here. So I have to lower this fold. So you can see this fold kind of right here has been lowered substantially to accommodate that implant. Another example, your typical trans female, very widely spaced nipples and almost no breast tissue at all. And then you can see here, the distance from this nipple to that fold is like a centimeter or two. That's like hardly anything at all. So I knew I was going to have to lower that fold substantially in order to get her the result that she wants. If you look at this head on, this is going to be your typical result long term. You know, if you're going to look at that, you can say, wait, it looks like those breast implants are spaced too widely apart, but look at where the nipples are located, right in the middle of that implant. If I put these implants too close together, her nipples can be kicked out and it will look really abnormal. But you can see the amount of distance that we had to lower that fold. You can see here how much lower that is on this side, and all that extra skin we had to recruit from the abdomen basically in order to give her the result that she wants. And then that's her result on the lateral view, a nice result, a natural result as well. So this patient wanted, you know, she comes in and says, I want to be big, I want huge, you know, big fake boobs. And I said, look, you're rail thin, you know, you have no soft tissue that can really stretch out and accommodate, you know, so I don't think I can give you the result that you want in one stage. So I'll tell you what, I'll put in the biggest implant I could possibly squeeze in you. And then after the fact, insurance may not pay for this, but after the fact, we can probably go back and do a revision when things have stretched out a little bit, and we can open you up. So this is what she looks like after the first operation. Oops. After the first operation, you can see, so this is as big as I could fit in her. You can see her scars kind of in the fold there. And if I'm going to critique my own technique, you know, these implants are placed a little too close together. And you can see what I mean about the nipples being kicked out a little bit. This didn't bother me because I knew that this was almost a temporary operation just to get some more soft tissue here recruited. And then I took her back at a second stage and put in a much bigger implant. So you can see this is after the second operation, scars hidden in that crease. Now the implant may be a little close together, but you know, she really wanted this cleavage, insisted on the cleavage. But you can see the implant has been spaced a little bit wider apart, more centered under that under the nipple, with the result that I don't think I could give her in one operation. So if you come in and you say I want to be huge, just know that I can't put this huge implant in you right off the bat. That I'll probably have to put a smaller implant in, and then at a later date put a bigger implant. So some people say, well, what about tissue expander? So that's what I use for breast reconstruction for cancer. So if you had a mastectomy and you had cancer, which if you look at this patient basically, you know, has no breast tissue. So it's almost the same as having a mastectomy, right? There's nothing there to start with. I can put a tissue expander in, stretch it out, and then put the implant in at a later date at a second surgery. So it's still two surgeries, but it's a temporary surgery, put a water balloon that stretches out, and then I do a second surgery with a bigger implant. Unfortunately, insurance company doesn't always want to pay for that. They almost never want to pay for that. So the way to kind of the workaround is, all right, we'll get insurance to pay for your breast augmentation. We'll do that. And if you're not happy with the size, then we go back at a later date. You'll have to pay out of pocket, but we can put a bigger implant in for you. And so that's how we get around that problem. And that's her on the side view. You can see there's no way I would have been able to shove that huge implant in her small chest without stretching it out once to kind of accommodate a bigger implant. All right, so that's your top surgeries, befores and afters. And I just wanted to show you 3 pictures here of vaginoplasties of my patients. These are 3 of my own patients at varying ages and degrees of healing. So this is a young patient in her 30s here. She's about 2 months out. This is what your typical result is going to look like. You're going to have scar tissue kind of around the new vagina, which will fade with time. She's only 2 months out. So normally the hair will start growing back. She doesn't have any hair, but I encourage patients, don't laser all of your hair away, because you want to have a little bit of hair to maybe hide these scars. And then if you look at, this is the labia minora. This is actually created, and you can see the color change between here and here. The labia minora is actually made from skin from the foreskin and from some of the penile shaft skin too, to create that nice color differentiation between the labia majora and labia minora. I do make a clitoris from the glands, the very tip of the penis. It's about the size of a pea. You can't see it here, but we can kind of see it right there. If you spread the lips, you'll see a clitoris right here, which has full sensation. And this patient, as well as many of my patients, have already endorsed that they have orgasms from stimulation of the clitoris. They also will often endorse that they have fluid production when they have an orgasm. And sometimes it freaks them out a little bit. They say, Dr. Brosious, what's going on? Like, why am I producing fluid when I have an orgasm? And the reason is the prostate is not removed during the surgery. The prostate is often really small in the trans women from all their estrogen. And to remove that prostate, you run the risk of having incontinence, scarring of the bladder. It's really just an unnecessary step. So we don't even try to remove the prostate. We leave it where it is. But as such, some of the fluid from the prostate actually will be expressed into the vagina and enter the vagina when the patient has an orgasm. So not enough to like have penetrative sex. You still will have to use lubricant to have sex. But a lot of the patients ask me, what is that fluid? Where's that coming from? And that's why I have to explain that to them. And most of them actually think that's a good thing, that they can have that experience. If you look a little bit further, some of this yellow or this reddish tissue here is the urethra. So the patients will urinate out of that. So it allows you to urinate sitting down. And then the vaginal vault is actually in here. And so these patients are able to have penetrative sex. I just cleared this patient to have sex recently. And typically I make the vagina 14 centimeters long and 3 centimeters wide. And with dilators, you can even get a little bit bigger than that if you want to. And so this is what your typical result of a patient in their 30s. This is a patient in her 50s. This is early after surgery. You can still see she's had some stitches in there. And she's a little bit heavier, so it's a little bit puffier around here. And she had a little bit, I was talking to you about, like wound healing problems. This is just a very superficial split in the incision here, and that healed up. I actually saw her recently, it's completely healed now. So this is very common to have little areas where it opens up. This is why I tell patients don't sit for 3 weeks, because if you sit, you may split this open, and that's right where she did. But again, if you kind of move the labia or the lips aside, you'll see a clitoris in there, which is fully functional, full sensation, and then a urethra where you urinate out of right below that, and then the vaginal vault is here. And this is a patient, actually my oldest patient, who's actually in her 70s, I believe, or just about. So you can see a little bit less elasticity of the skin as this patient heals. Very early after surgery, you can still see those sutures haven't fallen out yet. All of the stitches for the vaginoplasties are absorbable. And so these will fall out eventually. So she's only like a month out of surgery. And then over time, this will actually scar down and heal in. And you'll get even a nicer result, something like this, where it's less puffy, and some of these scars will hide. So again, these are 3 vaginoplasty patients of mine who I've done in the past 6 months. Still don't have the final results yet, because really it takes a year. But for patients who are curious, what does the vaginoplasty look like when I perform it, what technique I use. So the technique I use is a variation of what they began using in Belgium. The person who I learned from spent time in Belgium learning this technique. And so then I spent time with her, and she passed that technique on to me. And I'm passing this technique on to all of my trainees, so that hopefully there will be more people doing these operations. As of right now, I'm the only one in the state of Nevada, doing the genital surgeries. So I'm hopefully trying to create an army of trainees who can go out and do these operations in the community here in Nevada, as well as wherever they go practice. So those are some examples of some of my own patients. So like I said, I would love to come visit hopefully when we're open up to have, the hybrid or in-person meetings. And I would love to show some other pictures and some of the befores and afters of some similar patients, and answer all of your questions kind of in person. But hopefully today was a good overview of what I've done here at UNLV, what I plan on continuing to do. And hopefully this is a breath of fresh air, because I know that this has truly been a desert in terms of care for the gender population up until a few years ago. So look forward to meeting everybody in person, and Thank you for giving me your time to talk about some of the things that we have here to offer in Southern Nevada.